now this is a frame of apical 4 chamber view. Now what do you look at this frame? Let us talk of segment by segment, because once you will record echo, this is basal septum, mid septum, apical septum, apical lateral, mid lateral and a basal lateral wall. Let us talk of basal septum. No, I am not saying everything is contracting, somebody less, somebody more. My question is, what does it show you now? Normokinetic, hypokinetic or dyskinetic? It appears hypokinetic if I compare with this segment. However, if I compare this segment with this segment, it still appears hypokinetic. And in this format, this segment is possibly a normokinetic segment, right? If you compare this segment with this appears to be hyperkinetic. And how about this basal lateral wall? Again looks hypokinetic. Basal mid inferior basal septum appears a hypokinetic, but this is normokinetic because this appears to be hyperkinetic. And why this appears to be hyperkinetic means this segment is hypokinetic, especially this part, and because of this hypokinetic segment, this appears to be hyper. In gist, this is apical septum is hypokinetic. Thickness is less than 50%. I will show you one example. What do you mean by akinetic? It appears to be thickening, but thickening is less as compared to this segment and this segment. Now compare this segment versus this segment. Compare segment by segment. Just don't jump saying that this is normo A or this. Divide this into 6 segments and then look at each segment individually. Middle segment is always a segment which has got a papillary muscle. Are we clear? So this is what is hypokinetic, and this is what view you should have for evaluation of wall thickening abnormality. You have been making good views, I am not saying no, but now today you should make perfect view where apex should be in this triangle, and machines have got this focus. Look over here, the focus is present over here. In your system the focus is over here. I have got 2 focus, you can have 2 focus over here. You are not concerned with these images, let it them blurred or whatever it is, we are really not concerned. Now we are really concerned about this LV when we are focusing on wall thickening abnormalities. Are we clear? Okay. Now let me go back and show you another segment. Same patient, no, not the same patient, different patient. Now look at this apex again, concentrate on this part. There is no thickening at all, and that is why I say you should have at least 300 guided echoes before you start commenting by yourself on wall thickening abnormalities. Not a difficult job. 10 echoes a day, 1 month. 5 echoes a day, 2 months. 2 echoes a day, 4 months. And 1 echo a day means 6 months you have done your job. So you should have at least 6 months of a guided training before you start reporting a wall motion abnormalities. If you will do at least 6 months of a workup, so you will do wall motions and you will be able to calculate good valvular gradients. Are we clear what do you mean by hypo, what do you mean by akinetic? Are we clear or not? That's what your impression should be. Okay, now look at this basal, what segment? Basal is a papillary muscle over here. So, it is two chamber view. So, basal inferior segment. So, what happens to the basal inferior segments? With every systole, it is going out. Dyskinetic. Second most important thing, if you look at this, there is no endocardium seen over here. Look at this endocardium over here. There is hardly any endocardium is seen over here. What do you mean by that? It's thinned out. If you will measure, it will be almost 6 millimeters or less than that. Which segment will become dyskinetic? Which is a dead segment. So, if you have a segment which is dyskinetic, if you have an angiogram corresponding to that particular segment which has got a 90% lesion, there should not be any angioplasty for that, because we are trying to supply a blood to a dead myocardium. And if I say in a local Hindi dialect, अगर भूखे आदमी को खाना दोगे तो खड़ा हो जाएगा, अगर वो डेड आदमी को खाना दोगे तो नहीं खड़ा होगा. Is that what exactly I mean to say? And that's what is viability. Say it again.
Is it aneurysm? Because in diastole also it is not.
Its word is it aneurysm? You look during diastole, it's straightening up. It does not remain in the same form during diastole. And I'll show you what is aneurysm now. Concentrate on apex. It remains bulged out all the times. And the ECG features of an aneurysm is ST elevation persists. If I give you all 4 segments together, aneurysm, no intervention, dyskinesis, no intervention, akinesis, it could be, it could not be. Akinesis could be a segment which is viable but not contracting, and hypokinesis segment is almost always viable. That's what 4 feature you need to learn while we are talking of a wall thickening abnormalities. So, what we are going to show today is, we are going to show you segments where we will have wall motion abnormalities in hands-on session. You should be pick up all those 16 segments together, and based on a territory of a coronary supply, you should be able to say which coronary artery is involved. Today at this level is which coronary artery. Tomorrow we are able to predict which segment of a coronary artery is involved. If I have to take my patient for angiogram, jolly well I will know which particular segment is going to have a lesion. and we are true 90% of the times, because we have to go by standard guidelines like 16 segments model, but variation in segments are very common because the coronary artery supply also varies. Okay. Now another question. Let's look at this echo picture again. Now what happens to this basal septum? Hypokinetic, right? How about this mid septum? Normokinetic. How about this apical septum, this part? It's almost akinetic. Apex looks to be normokinetic, this looks to be normokinetic, and this part is again hypokinetic. My gist of showing this clip is you can have a feature of both hypokinetic and akinetic at the same time. What does it imply? It implies two things. Mid and basal lateral wall is being supplied by left circumflex artery. Now remember the concept. You can think of it, write it off, put it on a wall. Mid and basal inferior wall, mid and basal septum. RCA. Slow, okay. Hypokinetic or akinetic. Slow means hypokinetic or akinetic. Mid and basal septum, mid and basal inferior wall, right coronary artery. But what is the most important feature of a right coronary artery is? The right coronary artery also gives side a branch to right ventricle and sinus node. So, if you have an associated right ventricular hypokinesis, you are doubly sure that we are dealing with a right coronary artery. Or you have a sinus bradycardia or a complete heart block, you are triply sure that you are dealing with a right coronary artery. So, whenever you look for a right coronary wall motion abnormalities, you should always look for right ventricular contraction. I will show you how. If a patient is off beta blocker and diltiazem group of derivatives, still in bradycardia, who is not a regular exerciser or a heavy weight lifter, it means possibly we are dealing with right coronary artery. And I will give you an example. A guy walk into a cath lab, echo lab, saying that whenever I walk, I get a giddiness and I have a fall. He was having syncope. He is right. Syncope can arise from a carotid vessels, from a brain, or from a heart. We said there are two options. Let's do a stress echo or we do an angiogram. We did a stress echo. At the heart rate when it was 148, it dropped down to suddenly 87 and he had a giddiness. Documented 148, 87. And when he had a giddiness, we stopped, put on a echo table, scanned, typical right apical hypokinesis. Basal inferior was gone. Two segments which were bad. And at least like we took him to cath lab where we did an angiogram, proximal RCA lesion. Other things, they could have a carotid lesions, they could have a vasovagals. So, my quest of saying these words are, patient is the most intelligent person, he will only come to you when he has got an illness. When patient is brought by relatives, majority of time is a feigning patients. right? Now you will not forget what's right coronary artery is. Then mid and basal posterolateral wall. Posterior and lateral, they are supplied by circumflex. Rest all LED, and that is why if you have a proximal LED lesion, the person goes into shock. 50% the myocardium is not working. So, in this patient what do we have? We have mid and basal lateral wall which is hypokinetic and possibly mid septum or part of a apical septum which is akinetic. So, I am dealing with two coronary artery territories. One is the circumflex, one could be LAD or RCA. And if I have got a right ventricular wall motion abnormality along with it, possibly I will say I am dealing with RCA. Are we clear? And once you will go back, never look only at 4 chamber to say that patient ejection fraction is this much and wall motion abnormality correspond to LAD, RCA and circumflex. You have to see all three views before you make a wall thickening abnormality diagnosis.